dear colleagues and friends, online, virtually, and also here in the Friday Center, welcome. You want to hear about faith-based organizations providing healthcare in low and mid-income countries, often in challenging areas. As I was saying, this is the place to be. Major religions gave birth to countless FBOs, congregations, charities inspired by religious values. Many of them are active in healthcare with their own facilities or supporting someone else's facilities. It can rightfully be said that religions are major players in healthcare. How do they work? Which are their awareness and experience about WASH? How can we increase collaboration for the well-being of local population for the sake of national and global health systems? In this side event, we will address these issues. 4 very different case studies will be presented. The affiliation of each case study presented is an organization inspired by Christian values, if not openly Christians. However, you will see their work engages several partners, stakeholders, including other religions and governments. A Q&A session will follow. Successively, we will host a panel with FBOs and guests from government and international organizations. This panel will dive into the issues of sustainability, scale-up WASH improvements, and collaboration. We will then have an open forum, an open discussion focusing on the very issue of collaboration, and finally, a colleague will kindly highlight some key takeaways. Dear colleagues, ladies and gentlemen, this is the program of the side event, United for Universal Coverage, faith-based organization as allies for WASH in healthcare facilities. Again, welcome. Now let me introduce Mrs. Lindsay Denny, an amazing WASH expert from UNICEF. Before the case studies, she will set the context by describing the role of some peculiarities of FBOs in those low and mid-income countries. Lindsay, you've got the floor.
Thank you very much. Thank you all for being here. In case it wasn't clear, I'm from UNICEF. I'm not from a faith-based organization. However, I have had the pleasure of working alongside many faith-based organizations over the last few years on WASH and healthcare facilities. And so first, I want to talk about why we engage, why are we having this session? Why engage the faith-based group, and who are these faith-based actors? And so when I think about the faith-based populations that we engage, there are 2 types of actors in particular. The first is faith-based organizations who are the technical partners. This would be, for example, the Catholic Relief Services, the World Visions, who come and provide their technical support. The other, and what I'd like to speak a little bit more about today, is about the faith-based service providers. And this would be those providing the service of healthcare in particular. So we have an excellent presenter that we'll hear from later, Nakata Njero, who's coming in from ACHAP, the African Christian Health Associations platform. And the Christian Health Associations are notable in particular. They serve up to 50% of the health services in any given country, maybe lower in some, but they fill a major role in ensuring that people have access to healthcare. It's not exclusively Christian. There are Islamic faith-based service deliveries. We see that in particular, they're serving the poorest of the poor and the most vulnerable. And this is often guided by the faith of caring for the sick. But we see that this is really critical in rural settings, in those last mile settings, is that they may be the only service provider. So I think as we hear today about the incredible work that's happening, there's this sometimes divide where we have the work that's happening with the faith-based partners and the work that's happening in the public sector, and there isn't always that alignment. And so excited to hear about the excellent work that's happening, but also hoping we can think about how we integrate and mainstream some of this fantastic work so it's not lost. The last thing I want to note here is that much of this work is coming from private, not-for-profit healthcare services. And there's an opportunity here to showcase the learnings here that might be innovative and being put together in this model that could then be applied in the public settings. And so I know UNC, you've seen this in some of the research you've done, but I'm really hoping that we can see some excellent examples that can then be shared with some of our government partners, this innovation that maybe is happening in the Ugandan Catholic Medical Bureau that then the Ministry of Health in Uganda could be leveraging. So with that said, I'd like to hand over to the moderator, Jean-Philippe, to open up for some great case studies.
Thank you. So we will go through a series of 4 case studies, and so I'm happy to welcome Kata Jeru from Kenya, from Acha, to start us.
Good afternoon. I didn't remember I had lunch, so I was checking if it's afternoon or morning. Because I am on a different time zone in my brain. Next slide. The Africa Christian Health Association's platform is an organization that works with Christian health associations who at national level in many countries are groups of or mission health facilities are organized in countries nationally through what we call Christian health associations. And as you know, about 50% of Africa is Christian. And therefore, we cannot ignore that kind of a population. We also have, like Lindsay said, between 30 and 70% of healthcare in different countries being provided by faith-based health providers. In sub-Saharan Africa, mostly Christians, but we work with all faiths. And therefore, we have a significant contribution to healthcare. HAP specifically is working in 32 countries, 43 associations, because in some countries we have Protestants alone and Catholics alone having separate associations. And these associations bring together up to 10,000 plus health facilities. And we have convening power. I like to joke that like the politicians, unlike politicians who in Africa come back to communities maybe once every election cycle, our faith-based leaders meet congregants every week. So we have quite an influence. So if you want a message passed to communities, you might be able to use faith leaders better than you might use politicians, because we have more access to communities than politicians or other people might have. Next. So what are some of the things that we are doing in health facilities, therefore, with this reach? We are able to do WashCon assessments in the health facilities. We have been able to procure and distribute supplies, various supplies in facilities. We are doing capacity strengthening of healthcare workers and cleaners. We're empowering communities to demand high-quality wash services because, like I'm saying, we have presence in the facilities, but also because of the way we work and the way faith-based health facilities are organized in ways that you will find a church, a school, and a hospital in one place. So using that kind of connection then, you're able to connect the community, the school, and the church, and the health facility together. And then we are also, because of the connection we have across the region, are able to facilitate shared learning. So what good thing is happening in Ghana that can that Tanzania can learn from, or Botswana or another country? We are able to put together those kind of connections. Next slide. What are the enablers? Wow, those colors. Leadership and governance. I had this even with the the session just before lunch that was talking, that the people from state were talking about leadership and governance and the importance of strong leadership at government level. Same thing at facility level. You need planning from the administrators, from the faith-based health facilities are owned by the church. We have learned the hard way that ownership is very important in many ways, and now with the reduced funding, we realize that the proprietors of these facilities are the churches, and the churches and faith leaders own this. So they need to understand so that they buy in and invest in this, especially now when we know that we are going to have less and less funding for everything. But we know that we have resources within the church that can be prioritized if the leadership understands. Then capacity building, I've talked a bit about that. Infrastructure and supplies, having reliable infrastructure and supplies helps to, is an enabler in the health facilities. And then monitoring and data systems, ensuring that we have regular assessments using the various tools. And it helps to ensure that when we talk, we are talking from evidence. That we can talk about what have we assessed, what have we improved, and if there's evidence, then we're able to replicate that. Partnership and coordination. We are not doing this on our own. We have various partners. When we need to do trainings, we are talking to Lindsay at UNICEF. We are partnering with Felipe at CRS and others. We have a partnership with our facilities, with the Catholic Church, through the Catholic Church, and the Church has supported. We're also starting one with the Anglican Church, and the Church has bought into the need for the health facilities to make sure that the wash conditions are good. And then we also think another enabler is sustainable financing and community engagement. When communities understand, and I'm sure I'm speaking to the converted, then there's dedicated, we get dedicated wash budgets and empowered faith and community leaders that ensure ownership, that understand the importance of wash in healthcare facilities. And as a result of this, we have had quite significant results. About 3,000 faith leaders, that should be faith leaders, have been engaged. Our website has resources that faith healthcare workers can use. We have an e-learning platform that helps to do capacity strengthening. We have webinars, and we invite anybody who would like to partner with us and extend knowledge to do that. So all these results are results as a result of the work that we've been able to do. But most important and very important is that there is need for us to all work together and to not think of WASH as another branch of health, but to think of how we can work together. How we get people working on maternal and child health to think about WASH? How we get everybody thinking about WASH? Because especially now we are not gonna, I imagine resources are going to be fewer and fewer. And if we do not look for how to best integrate WASH in everything that we do, then we are going to continuously, we will lose the gains that we made. Yeah, thank you.
Okay, so we have a few minutes if you have questions for Kata about the work, about our presentation. Please go ahead. I can bring the microphone.
Right, thank you. This is Rachel from Tier Fund. Really encouraging to see this network, and would love to be able to engage further. Just see you've got something there on data management training on the M-Water. Just be helpful to understand what data you're capturing on M-Water. Is it for healthcare facilities? Is it looking at assets? Is it looking at training? Yeah. Can you expand that a little bit more? Thank you.
We are capturing mostly healthcare facility data.
Functionality, ongoing functionality, or you're just saying that there's a healthcare facility in this location?
It's functionality. It's functionality, yes. Yeah. And
Thanks so much, and I think it's phenomenal to have that. You're such a unique person to have at this conference. We don't typically have someone who's overseeing such a large number of health associations, so really grateful to have your presence. I know that you've had USAID funding for Washington healthcare facilities. Obviously, that is no longer. Can you talk a little bit about how this is financed? How do you look at, when you look ahead on Washington healthcare facilities for the different Christian health associations, how will they be funding this?
sorry, how will they?
Fund. Financing.
So we had a very exciting project on WASH, and it had just started, and in February we had to stop. And so first thing is that the faith-based health facilities have not had a lot of work happening in WASH, and a lot of WASH work, funded WASH work, has happened in the public health sector. But we were involved this time. And when we were involved, we started by ensuring that there is a point person for WASH in every country. So we couldn't afford to hire, but from every country where we were involved at the national office, we were able to convert somebody into a WASH advocate. And then that person was trained, and they went down to the facilities, and we were just about to start doing assessments. However, we have a few countries that actually have WASH point persons, and we are using the circuit riding model a lot in trying to ensure that we build capacity in the facilities. And I think that is one of the things that we are really, really going to try and do that. And we are also lucky to have, especially for our Catholic health facilities, funded through the church, as well as the Rome Initiative, as well as we are trying to get the church to buy in at the highest level and provide resources for us to improve WASH conditions. So that's one of the ways we want to do it. The other way is by making sure that leadership, especially at health facilities, understand the importance of WASH. Then as they prioritize budgets, they're able to put in budgets for WASH.
Thank you. We'll take a last question. Or the last one will be here. Okay, please.
Henk Holtslag, host of Smart Center Group. I have a question. I have the impression that most of your interventions are focused on communal systems, health systems, etc. Have you considered also helping households? For instance, I give you an example. We worked with the Presbyterian Church in Malawi, and the people around the faith leaders were trained in low-cost improvements of household water. For instance, rainwater harvesting, simple well improvement, Satopan latrines. So they came with examples of that people can do themselves or are affordable at household level. Have you considered that also, that type of intervention?
Yes, I actually had a slide that I removed because this was a healthcare facility. Yeah, so community WASH is also something that we are doing. Like I said, as we continue to engage facilities, we're also engaging. And we're actually working with Lixil since the last 3 months. But this is at health facility. But yes, community WASH is also something we are doing.
Ryan, quick question. Oh, wait, it's okay. Okay, thank you, Kata. So you enjoyed his introduction and overview, so he's back. Evaldo. Do you want me to separate?
So, me again. Excuse my French and also my jet lag. The Dicastery for Integral Human Development is a central office of the Holy See. We are at the service of the Pope and of the local church. And we constantly dialogue with bishops, their teams, congregations, Catholic NGOs, and universities. We try to accompany the local church in order to identify and address those obstacles to integral human development, to human flourishing. We knew water and sanitation were a challenge. Still, no massive WASH survey had ever been done in Catholic healthcare facilities. WASH can be a neglected issue, and frankly, through some donors, it is easier to get a grant for new equipment than a grant for WASH maintenance. Many facilities, as you can see from the table, belongs to the Catholic Church. However, the situation can vary greatly among those facilities. It is not only an issue of location or of size, but also of ownership, of managerial skills, of access to funding, and so many different realities even inside one same country. Furthermore, keep in mind there are no top-down approaches. I mean, the Vatican cannot impose a WASH assessment. We communicated widely on WASH through the Catholic Church and received several interested feedback. We intended to have a sample to assess, a sample that would be achievable, that would be relevant, significant enough to raise the issue. So as you can see, 150 healthcare facilities in more than 20 countries, so mainly Africa, but also the Philippines, Haiti. Obviously, this is not representative of the entire Catholic health system. We used a tailored questionnaire aligned with international standards, including GMP indicators for WASH in healthcare facilities and delivery rooms. Results were an eye-opener, and we communicated a lot on those results, especially for water supply. Here I mean the distance from the facility and the water source, and toilets adequacy. We also noted that proper budgeting and maintenance plans are fundamental for WASH performance. So we uploaded and promoted resources such as templates for assessment, recordings from technical meetings and interviews. Those resources can be used and are being used even by healthcare facilities which were not involved in the initial assessment. The assessment first raw results are online, and the more detailed study has been published in an academic journal. Among the lessons learned, clearly prolonged partnerships, even outside the Catholic Church, and contact groups are fundamental, especially for the weakest facilities, often small ones, but not necessarily the small ones. So facilities who need support even to assess needs, even to fundraise. They need support even to do proper reporting. So there is a special role for organizations such as CRS or Juan Ciudad or a few others. Since they have the technical knowledge, they can oversee work, oversee equipment, liaise with donors, and manage reporting. Moreover, WASH truly demands a very holistic and transdisciplinary approach. I dare to say an integral approach: environment, poverty, justice, equity, etc. An integral approach according to Pope Francis' letters Laudato Si. It is an issue of human rights. Encouragement from church leadership is precious. Of course, cardinals and bishops are not technical experts, not WASH professors. Still, their encouragement is precious for staff, patients, and donors. Now, after almost 5 years, more than 80 facilities received financial support. So it takes time, but it can be done. It is possible. Sustainability, fact-checking, monitoring, maintenance, training remain major issues and will remain major issues. Indeed, several facilities were established precisely to attend poor communities, very poor communities. This is a reality which will not change soon, so financial stability will remain a challenge. Thank you very much for your attention.
Thank you, Tebaldo. So we'll take a few questions for Tebaldo. So raise your hand and I will bring the microphone if you have a question.
Thank you. Could we see that table that you showed again, please? This one, yeah. And in your survey, did you ask about water quality? Because not just water availability is critical, but understanding what is the quality of the water coming into the hospitals and healthcare facilities. Do you have any data on that?
So here I'm lucky enough since a colleague, Lindsay, may correct me if I said any mistake. But according to the standards we used, you can say whether the water is directly from a borehole, if it is chlorine, if it is treated, yes or no. So you can, let's say, the staff charged with the assessment didn't test themselves the water, but they could report what was exactly the source of water. So according to that, we can assume whether yes or no drinking water was there near the toilet, yes or no, was in the delivery room, yes or no.
So just to clear on the assessment, we didn't do the full WashCon, Christine, that you're thinking of with water quality. We basically did the JMP questions with a few extra. It was meant to be pretty streamlined. In many cases, the health facility staff were helping us. This was during COVID. So the facility staff or fathers, the Catholic Church was actually helping do the assessment. So there wasn't necessarily technical expertise and ability to do water quality testing. I will say the findings from this though, and this is not to throw the Catholic Church under the bus, Tebaldo. The status of the healthcare facilities on the WASH, I mean, he's kind of got it down there, yeah. And there is an article about this, you can read about the actual findings. Yes, it was about the same as you would have found in public healthcare facilities. There wasn't a drastic difference when we compared the JMP status in that given country to what we found with the survey. And these surveys, it was only 150 facilities, so it's not, we don't have a representative number, but we were seeing similar types of gaps in terms of water access, et cetera, compared to the JMP. So I imagine, Christine, the same kinds of water quality issues that plague public facilities you would be finding in the Catholic facilities as well.
Thank you. For the sake of time, unless you have a very critical question, I'm going to invite Kimi Gerken. Is it? Oh, okay. Kimi Gerken from the Water Mission for the next presentation. Do you want one like this? Do you want me to?
I can take the slide. Thank you. My name is Kimi Gerken, and I am here today representing Water Mission. At Water Mission, we aim to honor God by developing, implementing, and sharing best-in-class safe water solutions. And so today I'm going to share a little bit about our work in healthcare facilities, how we started working in healthcare facilities, and then share 2 case studies of our work in Honduras. Water Mission hasn't always worked in healthcare facilities, but starting in 2019, we were asked to respond to the Ebola crisis in Liberia, and shortly after started a global response during the COVID-19 pandemic, where we implemented short-term systems and short-term solutions, including water systems, wash programming, hand washing facilities, And during that time, it strengthened our ability to understand the local context in healthcare facilities where we had a long-term presence. So from these partnerships and as they grow, we started more systematically working in healthcare facilities and now work in 45 healthcare facilities across 7-country program where we have a long-going established presence. I'll start with our first case study, which is in San Isidro. This partnership started with our funder Grundfos for Good, and they were shocked during a visit when they came to this hospital and there was no access to safe water. Not only did this hospital not have access to safe water, but they had inconsistent water that was often available or not available, depending on the time of day from the municipality. This was a much larger project than Water Mission had taken on at that point, where we had to connect into municipality taps, dig a new well, store that in a cistern tank, and then figure out a way to distribute safe water throughout 320 taps in that hospital. So not a small task. We did accomplish that, and from a win side of this project, before I talk about challenges, it enabled Water Mission and positioned our Honduras team to shift our programming and communities we serve from more community-based kiosks, where communities would walk to a kiosk to fill up their cans and go home, to starting to do more household connection projects in Honduras. However, we experienced a few challenges with this project with inconsistent chlorination once we handed that project over to hospital staff. So during the project and while we were implementing, we did community development activities with hospital staff where we did training on wash, sanitation, hygiene, as well as how to properly chlorinate the system to make sure that safe water was flowing through all these taps each and every day. We quickly learned that hospital staff is really busy, and they weren't always having the capacity to have those proper levels of chlorination. The second aspect of this project is that we designed it so that not just the hospital could access the safe water, but the community at large could. And so the program design was so that the community would be able to buy bottled water from the hospital alongside ice. And so we established a safe water committee that was supposed to manage this part of the outreach, and quickly learned that those sales were not happening throughout the community and that water was really being held at the hospital. The lessons learned as we continue to investigate why we were seeing some of these less desirable outcomes was challenging political dynamics between hospital staff, the municipality, alongside the community. So moving forward, we took those lessons and stakeholder engagement from the very beginning, and also noting that we couldn't assume that hospital staff could just take over the system and assume that they would run it efficiently every day, and try to apply those lessons learned in our next case study, which was our next big hospital project in Honduras in El Progreso. So in El Progreso, they were also connected to municipality water, but there was insufficient water supply. And so we were asked to come in and, again, drill a new well, store that water, and distribute it throughout the hospital. A note about this project is we did connect it to an already existing electrical grid, and the project was up and running well. And as we did our follow-up routine checks and water quality testing, we noted that the tests weren't always coming back as we would expect. And so through further investigation, we learned that the cost of water by connecting it through the electricity grid was an issue for the hospital in their budget. And so what they were doing to meet their water needs was using the municipality water until it ran out, and then supplementing their water with safe water, therefore mixing their water, and then it not being safe. Overall, these two case studies highlighted the need to start with stakeholders in the very beginning with strong WASH programming and working with not just like in a normal typical community project, you're working with the community stakeholders, but expanding that to have more upfront conversations with the hospital, not assuming that they can just take over the safe water system without followed up support, just like we would see in a community. Thank you.
Thank you, Kimi. So we'll take a few questions for Kimi.
this whole panel gets an award for honesty, and the challenges. So those challenges are so real. So the question for you will there be follow-up work, and will you be able to continue to help these improve their services? And then does Water Mission have a longer-term strategy, to expand this work in Central America?
Will this one work? Yeah, thank you for that question. Something I really love and appreciate the way Water Mission works is we continuously to have monthly follow-up checks with that community. So one, we do use remote monitoring to know when a system is down and when there's functionality. We do routine water quality testing, and we don't go away. And so we are continuously working with that capacity building in healthcare facilities. I'm trying to remember the second question. We do continue to work in Central America, and we're moving more towards, like I shared earlier in the San Distro case study, towards more professionalized services where we're doing household connections in targeted service areas.
Thank you, Kimi. Please, everybody to thank Kimi. We have to move to the next case study. So I'm calling Sydney Shear. Excuse me for the pronunciation.
Perfect.
Do my best. Welcome from World Vision. Do you want to handle it? Okay.
Can I have one of the...
Do you want the mic?
All right. Good afternoon, everyone. My name is Sydney Shea. I'm with World Vision US, and I do have the privilege of sharing some information about some WASH and healthcare facilities work that we do currently in Niger. I'm just going to highlight one specific program. There is much to share about our health facilities work at World Vision, even just in the country of Niger. But since we're pressed for time, I'll try to keep it a little narrow. I don't know about all of you, but due to the craziness of this last year, I have not been able to travel as much as I would like to the field, so I thought it might be kind of nice to bring a little bit of Niger to Chapel Hill. And I do have a video that the team put together there, so we're going to start off with that.
Wanda kayan wanda sai Dr. Kwarara Gangu Komin Kargibongo Region de Doso. Gumanda sai Dr. Kwara ago Dr. Kwara waya. Ka act to serve. Barmayan wukan ide goyora. Barmayan bobon. Afu Dr. Kwara goy city da harsil. Zama haru banda no hanane yan wugo. Dinga ba hanane da harsil ni sahana. Iddu haru iddu barmaya. Di sambu hayyan wudu. Banda irgi hingadu way bor way cendugu. Way bor way cende iya son irgi ko halwaran ka cende hen kalwaran ka cendu. Di koy safarado irgi hinkadu bor zon wanda way banda. So irga ko hal bor zon ga yenza. Hal son ga yenza da way. Ai go sa war division. Ai mayo bon da kauya bora me ame mayo bon. Da hanan yan ka ikandirse. Kada irba funara.
All right, hope you enjoyed that. I love that video. So you may have heard that woman in the video mention something called Act to Save. And that is basically the name of a privately funded program we are currently implementing in Niger between 2023 and 2027. Just to give a bit more detail on it, it will be targeting 150 healthcare facilities across 18 different communes and a number of different regions as well. Dosso, Maradi, Tawa, Tillabéri, and Zinder regions of Niger. I can share a bit of our achievements as of 2024. We're a little too soon to have our 2025 numbers. I wish I could share those with you all. But even just what was achieved by 2024 is quite remarkable. So just in about a year and a half of this program, 50 health facilities were reached with improved WASH access. And yes, that is water and sanitation and hygiene access at all of those health facilities. 103 health facilities received staff training in integrated management of childhood illnesses and also on infection prevention and control. And then over 7,000 community health workers were trained using the integrated community case management model, which was used to identify and reach over 150,000 children in those catchment areas. So building off of our long-standing WASH and healthcare facility work in Niger, as well as the progress made so far in this Act to Save program, there are two key enablers of sustainability that I'd like to call out here. The first one is our government engagement. So something I'm sure many of you all are familiar with, I think there was a session this morning on WASH Fit. That is something that World Vision in Niger has really stepped up to collaborate with the government on. That's the Water and Sanitation for Health Facility Improvement Tool. So that is currently being implemented in 6 of 8 regions, covering nearly 500 healthcare facilities. And something else that I do want to call out that I think sometimes we maybe overlook a little bit as a non-governmental organization is supporting the government on the development of strategic national documents. And so that is, again, part of our government collaboration with World Vision in Niger. And there were actually too many for me to put onto this slide, but just to call out 1 or 2 from my notes, is that we did help support on the National Strategic Plan for WASH in Health Facilities, which is from 2022 to 2026, and the National Strategic Plan for Healthcare Waste Management from 2025 to 2029. So having those national level government documents really can be quite pivotal in providing a foundation to work off of, but also just in ensuring the long-term sustainability of the work that we do in healthcare facilities. The second point here, which is what brings us all together for this session, is that engagement with religious leaders, but particularly in Niger, because it is an interfaith context, this is also quite pivotal. So as a part of this Act to Save program, World Vision Niger did collaborate, again, with the government, but in revitalizing something called the Inter and Intra-Religious Dialogue Committee, CDIIR. This was established by the Niger High Authority for Peace Consolidation. So kind of bringing in a couple different actors here. But that is particularly crucial to peace building amid any rising tensions that might occur in an interfaith context. And once again, as has been highlighted by other case studies here today, leveraging the influence of religious leaders for community health as well, and just acknowledging that places of worship are community gathering points, and religious leaders do play a strategic role in the sustainability of health messaging to support the work that we do in health facilities. And that is all that I can share today on this case study. So thank you.
Thank you, Sydney. So we will take very few questions. Please go ahead. Not less than few.
Thank you very much, Sydney. Just a confirmation. This Interreligious Dialogue Committee was created for something else, for other purposes, and then you also use it for WASH? Or since the beginning it has been created for WASH?
Yes, good question. I do believe I skipped over that, but they do help to identify religious leaders in communities. So that's the main function of this committee. And so it's used for many functions, not just for WASH, but yeah, is the main mechanism that NGOs like World Vision can use to help to identify who those religious leaders are in communities.
You may not know the answer to this, but I'm curious from the video where she talks about these substantial increases in number of births, number of patients. Presumably that translates to an increase in facility revenue. Do you know what happens to that revenue? Like, is it being fed back for operations and maintenance of the systems that World Vision has installed, or does it go sort of more generally into the healthcare facilities budget, and sort of how you're seeing changes to the facility based on this increased revenue?
Yeah, that is a great question. I don't think I have a great answer for you. But I will say, yeah, as you've mentioned, presumably with the increase in revenue, there are also an increase in cost to serving all of those people. So I'm assuming much of it's going back into health facility management. It is common for both limited mechanized systems to be built at a health facility and to connect a health facility to a community mechanized system. So in the cases where there is just a limited mechanized system at a health facility, I would also assume more of that revenue is going towards the account to the savings account for maintenance of the system as well, so that we have the long-term sustainability of taking care of that. Because when it's connected to a community system, there's a community management. So if something were to break down, there's already a system in place for collecting the financials for that. So it's a little bit different when there's only just a borehole at that health facility, and so the increase in revenue also contributes to that.
Thank you, Sydney.
Thank you.
So for the next segment, we will be on a panel discussion. Okay. So we will have a panel discussion that will be moderated by Ryan Cronk, Assistant Professor, Department of Environmental Sciences and Engineering here at UNC in Chapel Hill. So this panel discussion will focus on sustainability, on scaling up, and collaboration with the government.
Great, thank you. Why don't we go ahead and have our panelists come up. Jean-Philippe, who you've been hearing from, Nkatha, Lindsay, and unfortunately Dr. Mary will not be joining us today. She flew in very early this morning and was on the plenary panel if you were there. So she'll be joining us tomorrow morning for our healthcare events tomorrow. Yes, we've heard a lot of really great case studies today, and thank you for all the presenters. I'd like to for the panel to reflect a bit more on this issue of sustainability and scaling up solutions. Maybe first on sustainability. What does sustainability look like in these faith-based contexts? How do we go about ensuring that these projects and programs are sustained in the long haul? Especially if they have sort of diverse funding sources that it might be relying on and not necessarily having the same type of government intervention. If anyone would like to jump in first.
Thanks. I'll speak to sustainability from a wider lens. And I'll speak to sustainability thinking from especially where we are. And one of the things that I think is going to help us is how we organize our projects. Like from the beginning, we have to think about the end from the beginning. What happens when I am no longer here? What is going to happen to this work that we have started? And one of the things I like to say is that the faith sector is, we are one of the people who, we are not projects. We are, the faith sector is, we are here because of our mission to serve. And so with or without the funding, we have to, these hospitals that were established by the church have to continue serving communities. And so if we think about integrating sustainability from the beginning by ensuring buy-in, by ensuring we ask the right questions, of course, some things will have to be prioritized. There's the good to have and the must have. Then we are able to get, we are able to maintain things that we need to maintain for our communities and for the people that we serve. So I think it's thinking about the end from the beginning.
I would say that sustainability itself doesn't look different in a faith-based healthcare facility than a non-faith. Like the literal action of what needs to be maintained does not change, right? But what does look different, and something that you're referring to, Nakata, is the management authority might be different. And thank you to Tebaldo and all my other faith partners who've given me a crash course in the varying mechanisms, dioceses, et cetera, to understand the various authorities that come into the conversation. Because that's what's, I think, quite different than if you were having a Ministry of Health structure that perhaps non-faith partners are accustomed to working in a secular setting. And so the role, for example, of faith leaders, and multiple of you presented on that, they may have a role in influencing what sustainability looks like, how the funds are spent. The question just now to Sydney about how that money of the user fees, like that can all be shifted by, I think that was a public facility you were looking at, but say that we're a faith-based facility, it might look different based on the way the Christian Health Association approaches the individual facility management. So I think that to me is the biggest change that we would really need to address when working in these settings, is understanding that context, that governance, which looks quite different. I think the other thing is, the last thing to say is what you're referencing here as well is the reason for why the driving mission might look different, and that's going to be affecting decision makers and how they decide to allocate funding, allocate resources might look different than what a Ministry of Health decision maker is driven by. And so understanding that and being able to speak to that is really critical.
At CRS, over the 5 last years, we've supported over 450 facilities across 16 countries. So definitely how we approach sustainability, first, we have to adapt to the local context. We don't find the same, we have some, I would say, some patterns of factors that support sustainability, but a major one is to understand the context and to adapt to the context. So this is about stakeholder engagement also, and in all aspects of my work in WASH, it's like the first focus is get to know who are the stakeholders, what are their roles, what level of influence they have, and how to work together. So also part of this is to consider a systems approach. We consider the health facility as a system, and it's maybe a small system, but with many different pieces and people who have functions, etc. And it's within another system. Like if we take the example of the Catholic Church, there is the support from the Catholic Church. Sometimes you have even some technicians, focal points, and Kata talked about circuit riders. They play an essential role in providing this continued technical assistance post-project. So we look really at the system approach. The other point when looking at this is not to forget, and it's one of the important questions of this panel, is within the system there is the health system, the national health system. And we are not a parallel system to that trying to having success. The important we want to integrate into improvements in national health. So that's where the collaboration is important. The last point, and this one has been highlighted in all the assessments that we did on sustainability, is the importance of focusing in our sustainability framework. We have management and planning. And when we look at established services, what we found really essential if we want the services to be maintained over time at a good service level, water quality, availability, continuity, etc. If I take only this example, is good management, so how we support management system, and the planning. So planning is looking at what we call life cycle costs from the beginning, how we can project those long-term costs and consider them from the beginning. So yeah, the focus on all aspects of planning, supporting how to plan, how to monitor planning that is executed is another major factor that we consider.
Great, thank you. I'm wondering if we can pivot a little bit. I'd love to hear more about promising opportunities to strengthen collaborations between faith-based and government-led healthcare facilities to improve wash services. If anyone has any initial thoughts on that.
Happy to go first. I wrote a concept note on this last week, so hopefully I know the answer. I think that, I mentioned this at the start, I think there has been a bit of parallel work, and not exclusively, CRS, World Vision, and many of you, have been engaged in the conversations, but for example, the work, Tebaldo, that you all have done with the Catholic Church has sort of been on the outskirts of maybe the primary dialogue on wash and healthcare facilities is kind of being brought into the fold. And I think there is a role here to be played to learn amongst the faith-based community about this work, but then to ensure that those lessons don't get sidelined, that they are brought in, because there are very similar lessons. I mean, I mentioned some of the big gaps that we're seeing in the Catholic facilities are similar to what we see in the secular facilities, but and the lesson learned are similar, but the approaches might look a bit different. One of the things I'm excited for in the next year is to engage the faith leaders in this dialogue and to see how we learn from them and ensure that they're carrying the messages back with them, and vice versa, that they're being heard in the spaces of UNGA and some of these high-level platforms. And so I think there is two efforts that need to go underway, one of which is to ensure that in platforms like this, Tebaldo and CRS and others are invited to share the work at these sorts of forums, but then vice versa, when we have an event at the Vatican next year, that the secular voices come in and are hearing that exchange is happening both ways. So I think it's a lot of intentionality in ensuring that that dialogue is not happening on two parallel tracks. Hopefully that answers your question.
Strengthening collaboration with the government is essential, and there's the term collaboration. I think it's important to really to dig into what we can do in collaboration. So if I take the example, and in establishing a good collaboration, it's being at the service, understanding the needs. So I will give an example. Our team in Ghana, we had a program called ICO-WASH that was supporting WASH in healthcare facilities. And from the beginning, I talked about the stakeholder engagement. One aspect of this was a consultation with the government, with the decentralized health services that you can have in Ghana, for example, at district level. So really to respond to the needs where we intervene, to enter into a discussion with them on what could be the contribution, how this could happen. And the request came from our partners from the district assemblies that they needed some sort of guidance, some sort of practical toolbox to work on how to improve WASH in healthcare facilities. So this was not like coming and thinking, oh, okay, we think we need to strengthen this aspect. It was a dialogue to get to know what was the need, and with the spirit of collaboration. The last point I would like to raise, it's data. Kata talked also about evidence. We think that so what is missing for the faith-based facilities that are known to do very good work is there is a lack of visibility, of good data, of evidence to show how we contribute. And this helps for the collaboration. Because when you enter into a collaboration dialogue or debate, or it depends how well it goes, we all know it. It depends on your credibility, how it goes. And the best way to do this, we had examples also from other presentation on using WashFit, which is a very good tool to really measure multiple indicators showing the quality of the service that is established, and over time to repeat and being able to show this is what we were able to do, this is how we were able to establish sustainability, and this puts us in good conditions to be able to strengthen our collaboration.
Yeah, I think you've said it all. I was going to talk about it. I think the other one is accountability as well from both sides. And maybe just to mention that is an opportunity for a lot of you who are experts in WASH to contribute to the faith communities, because we have a lot of things that are happening, especially now that there is increased interest by leadership and governance systems in the faith sector to improve WASH. But we need greater investment by experts in WASH into the faith-based health systems.
Thank you so much. You're right on time. Let's give our panelists a round of applause. Do you want me to go on the transition to them?
Thank you, everybody. So now we would like also to hear you on all those topics and issues. So particularly, you know that our focus is to understand how we deliver more sustainable services, how we contribute to health, not only to WASH. We are talking about integration as well. And we have talked about collaboration with the government, which is dear to our heart, how we can contribute to the system. So we are going to move to an open forum where moderated by Ryan, again, thank you. And I will move into the room and we want to hear you, unless you have guiding questions, Ryan?
Yeah, we have a few guiding questions, but we would love to hear from you all in the room. I know we have many faith-based organization actors, and we have other folks who do WASH in healthcare facilities, and hopefully maybe if there's any government voices, we'd love to hear from you. But maybe just an initial question to lead off with, kind of building on our discussion around government engagement. How can faith-based organizations better align with national WASH strategies? So maybe some other questions to think about related to that would be how can faith-based organizations effectively engage their government counterparts, and then what opportunities exist to leverage relationships with other local religious leaders. So again, I'll state our overarching question again really quick. How can faith-based organizations better align with national WASH strategies and engage governments? If anyone wants to kick us off.
Thank you very much. My name is James Amanda. I work with CUAMM in Uganda. I don't know whether I'm responding to the question because I have 1,000,001 questions in my head. I work very closely with the Catholic Church. I serve in the Catholic Church, my parish, my small Christian community. And I've always asked myself, what is it that makes the mission, the faith, healthcare facilities unique? What is their niche? How different are they from the public facilities? Because in Uganda, for example, the big Catholic hospitals, Zambia Hospital, the Little Sisters of St. Francis, Kokonjero, Little Sisters of St. Francis, they are really big hospitals. They are big referral hospitals, but they're very expensive. So what would attract? I go to Zambia Hospital, but I know it's very expensive. But I know I can quickly see the consultant. There are not so many long lines. So probably those are things that attract people to such hospitals. They have a value system because they believe in certain things, ethical standards, and so that may also be attracting people to go there. But in terms of alignment with the state, they work within the state. There are state policies, health policies that govern all the health facilities, irrespective of whether they are public or not. And if they don't, then they are also held liable if they fall short. And we've had cases, especially cases related to maternal health, where women die in labor for negligence, or they do operations and they leave stuff in their bodies. It's the same thing that also happens in the public facilities. So I think for me, the alignment, there shouldn't be any question about alignment. You work, you operate in a country with its policies, so you respect those policies. I think what the facilities need to do, what somebody talked about, increasing visibility based on niche. What is it that sets this particular facility apart from another facility? So why should people go there, even if they're expensive? You know, you'll hear stories, oh, but we have nuns, like in Zambia Hospital. The Cancer Institute is run mainly by nuns. That could be an attraction. If you go to the radiographers, the people who work in the scanning, they are nuns. That could be an attraction. So that attraction gives it visibility, and it needs to be made clear that this is what sets this particular institution apart from the many others. Thank you. I don't know whether I've answered your question.
No, thanks for your insights. You have another question in the back.
Joshua Knight with the Catholic Engineering Corps. I mean, I don't want to sound quaint. This is kind of obvious, but I was thinking three things that we work on when we do project. I do mostly water projects, but try to make it a full wash project when we go into countries. We start with the bottom up, so we'll start with the local government, especially when we first come into a country. The federal government couldn't care less about us, but at the same time, making sure that at the local government level that they're agreeing with our project and hopefully partnering with us and giving us something. And then secondly, researching before, during, and after our project, what are the rules that we should be following, just as was pointed out here that, we're foreigners, we want to make sure we're doing everything right. And then also the last thing is staying there, right? When you have a staying presence in a community, they get to know you, and you can start to move up from a local to a regional to a federal level.
Thanks so much for that. I just want to say if anyone online has anything they'd like to chime in, feel free to jump in or type in the chat, and I can read it off to the audience. Christine.
Thank you. So I have a question for the different organizations that have presented your case studies, and that's about what type of memorandum of agreement or understanding do you have with the national government or the local government or the hospital itself when you're giving these donations of infrastructure, new infrastructure, infrastructure repair? What type of arrangement or agreement do you have for sustainability, for who contributes what? And Lindsay, I know you did a lot of these agreements in Cambodia. What are the lessons learned from these agreements? What works and what doesn't work? Thank you. That's a question.
Anyone have any insights?
Okay, I can talk about a project in Ghana. Sorry, I don't know the legal terms in English, so I will try to. But what they do is they work through a memorandum of understanding, which I understand is not. It's where I'm not sure to use the right term, but it's not like it gives some freedom. Let's say it's not contractual. So where there is a description, quite a detailed description of objectives, of the common objectives of the two parties. So through the Ministry of Health or decentralized services at the level of where we intervene. Mm-hmm. So there is a description of what are the objectives of the health services and of intervention of CRS. What are the duties and description of duties, and other aspects that are related that you would see in other MOUs about communicating, etc. And so this is in general, I don't have a particular example in mind, but I know it's between 1 to 2 years duration, so that it can be reviewed, amended as necessary.
And does that promote sustainability of the program and the donations?
Yeah, it's described of the sustainable aspect, of course, is to maintain the services over time after, like the, let's say, post-rehabilitation or post-conscription period is described. So it depends, you know, on the MOU. We don't have a typical one. Again, as I was explaining in our perspective, it's all related to the context, to the dynamic of the stakeholder engagement and the relations with the stakeholder. Sometimes it's requested to go deep in details, sometimes less. It depends on the relations in the field, I would say. And Katai?
Yeah, I think just to add to that, it depends on the context. So some countries are very determine what kind of relationships they want with anybody coming into the country, and some are more hierarchical, where you find that you must start at the national government before you get to the health facility. In other countries, it's fluid, so it depends on where you are, but my experience has been there's a lot of advantage in making sure that you go through the system and create relationships with the government, if they're asking or not. Because eventually you will need those relationships. But also one of the things that I have realized is that co-creation is very important as you come in, so that you're working with both the facilities, but also the government. About 3 months ago, when we started working with Brazil and putting in the SATO products into countries, we asked Uganda, Nigeria, and Tanzania. And Uganda did not, for some reason, they at the moment have not accepted the products because they were not making sense to their situation at that time. But they were donations, so we could have brought them in and just gotten into the facilities, but they would not have been as useful. So we were able to provide more to the other countries that know, because it now comes from them. So I think it's very important to ensure that there's co-creation, but also that you create, if the relationship or the requirements are fluid or not, it's important to create those relationships because they help you with sustainability.
Thanks. One last comment here on this question. We'll move on to the next question.
Thank you. I wanted to just say about the church partners, particularly in Ethiopia. They are covered almost all regions, so they are closely working with the local government. They are very close to the communities. For any support they are, even in some places, they are very close than the government itself. So they are supporting with WASH, agricultural, even in health aspects. Particularly, I know there are hospitals, Catholic hospitals, which are built at the community level, not in the cities. So they are supporting, they are a referral hospital at the rural areas. So they are working closely with the communities, even sometimes free services for the poor. This is a relationship at the local community. Regarding the national government, there is an MOU the church partners signed with, particularly I know with WASH, we signed that MOU with Ministry of Water for tax-free importing of material, like ambulances, like drilling machines. So there is an MOU signed with the government. So we do have a good relationship in that regard. So this is supporting the government. Having a drilling machine in the country a big asset for the government itself, because naturally the Ethiopian groundwater level is very deep, so we need drilling machine. So in that regard, the church supported CRS. Even in the last 10 years, we imported and donated more than 6 rig machines. This is a big support, and it created a good relationship. Thank you.
Thanks so much. I want to pivot to another question before we wrap. Many of you in the room have been doing Washington healthcare facilities for some time. Some are just getting started, and some are thinking about getting engaged. I'd like to hear a little bit about what kind of resources you need to pursue and advance this work, whether it's technical support or support around advocacy or engaging in government. I'd love to just hear from the audience. As many of you know, UNC leads the Washington Healthcare Facilities Community of Practice, and one of the things we'll be launching this year is a faith-based working group to help develop out these types of tools and connect people and resources. So we'd love to hear from the audience what might be needed to support you in your work, whether or not you're just getting started or you've been doing this for a while.
Thank you. This is Andreas. I'm from World Division. So when we talk about health facilities, mainly we are talking about health professionals. Health professionals are in a best position to understand what we are talking about, especially the WASH thing. So as part of curriculum developing health professionals, it's good to engage, create a curriculum which includes how to mobilize resources in a given community to support, health facilities. So after health professionals graduated, they are assigned to those health facilities with poor WASH conditions. So instead of for them to figure out later on what should be done, if they are trained early on during their coursework, how to mobilize, resources, how to engage local leaders, how to engage faith-based organizations and government, so that they may, when they get that actually rolled, they may not be surprised, so that they may be well positioned to support the system. So curriculum development, curriculum revisiting, and reshaping their curriculum might be one of the suggestions.
Thanks. Any other comments?
I'd like to build on this comment about this curriculum reshaping, updating, but without giving for granted that the director of the healthcare facilities is necessarily good on WASH. Especially we had some challenges in healthcare facilities specialized in mental health and drug addiction. So let's say director were some religious friar, top, let's say, human resource manager, top psychologist, but he really neglected for some time problems of toilets, of sinks. Well, we still have other toilets functioning, just close that one. Oh, let's close that one, we still have another one, close that one, and the wall almost collapsed in the end. So there are challenges. So this idea of constantly updating is a key. To who should I?
I think that there are some advocacy materials that would be really helpful. Nakata, some of the work that your Christian health associations have done, bringing together when the health managers all come together, the health facility leaders, once a year, having these meetings, and you can raise Washington healthcare facilities as an issue and talk about it in a budgetary sense. To have some materials that could be reflected on from this community and could think about how to best tailor it. And it's a little bit along the lines of what he's talking about with education, but a little bit more in driving the conversation on budgeting. If we could have some things that are ready to go and Nakata can share them with the Ugandan Catholic Medical Bureau to say, hey, you're having a meeting next month. It's going to be all the every director from every healthcare facility in the entire UCMB system, and we can talk about the importance of WASH, and here's like plug and play information. I think that would be really, really instrumental.
Great, thanks. All right, we are almost at time. Oh, one last quick comment, go ahead.
Maybe one suggestion and share experience from Malawi. We worked in Malawi with the Presbyterian Church, and they had a wash specialist. They employed a wash specialist because we see in practice, simple is not easy. Even you talk simple solutions, simple technology, you need a specialized person that can decide it and advise, that can train, etc. So that may be an idea that faith-based organizations employ a wash specialist to give technical assistance.
Great, thank you so much. All right, we're going to transition to wrap up, which my colleague Nikki Benke is going to help summarize our session, and she's also going to plug our sessions tomorrow too.
Okay. Hi everyone. As Ryan mentioned, my name is Nikki Benke. I work at the Water Institute as of about a month ago. I was also here about 5 years ago as a staff member and a student and an undergraduate student. But the reason that you see USAID, because this is my most recent headshot, is in between I was at USAID for about 5 years. So I've been working on Washington healthcare facilities for a while with Lindsay, with Darcy, with Ryan, some in the research space and then a little bit at USAID as well. And I really want to thank our panelists, presenters, for such a great session today. I feel like there's a lot of insights, and something that was really helpful for framing for me was hearing Lindsay's comment about how they're not all faith-based it's hot today. Faith-based organizations are the same. There's kind of the technical partners who come in and support healthcare facilities, but then there's also the religiously affiliated healthcare facilities. And so those are two kind of different types of actors. A few things I wanted to kind of summarize as key messages that emerged to me through this session. One is that if it's a faith-based organization run or supported healthcare facility or a religiously affiliated facility or a secular facility, a lot of the challenges are the same. A lot of the approaches and tools and solutions are the same. They don't necessarily change. What does change is sort of the comparative advantage of faith-based organizations versus non-faith-based organizations. Faith-based organizations have a different type of reach and access to communities. They are really involved in communities that might be really rural, really remote, very vulnerable population. And they also, for the ones that are religiously affiliated healthcare facilities, the church has regular touch points with the community. So that's an opportunity for messaging. That's an opportunity to leverage that local leadership. Another thing that came up was the ability of faith-based organizations to innovate and kind of pilot approaches that can maybe be adapted at the government level or adopted by the government later on. Something where this came up with Water Mission mentions the approach of selling the water bottles to the community, and that wasn't something that worked in that case, but maybe in another context it might. I think that's an example of thinking outside of the box that a faith-based organization as a technical partner might be able to do because they have a bit more independence compared to a government partner. And then another thing that came up was interactions between communities and healthcare facilities. I heard a few different models for how to handle this. Having spent a lot of time in healthcare facilities in Malawi, I know that no two healthcare facilities are the same. In some cases, there's a health post that has 2 employees that's in the middle of a village, and it might make sense to do something like what Kato was saying, or no, it was Sydney was saying this, about extending the community water point to the healthcare facility. In other cases, it might make sense to use the healthcare facility as a community source. In other cases, they should be completely separate. So I think thinking about that interaction between the community and the healthcare facility makes a lot of sense, and we need to be considering that moving forward. And then sustainability was kind of the buzzword today, which is not super surprising since it's very important. But something that really resonated with me, especially coming from USAID, where we were kind of wedded to the 5-year program cycle and the timelines and the funding and everything, was hearing about how faith-based organizations are not, the mission is much bigger than the project or the timeline. And Kata was saying this, she said it really eloquently. The mission is bigger than the timeline, so, or the project, or whatever work plan you need to submit. They have staying power, and I think there's a lot that can be learned from faith-based organizations that have really deep roots in these communities, where sustainability is not just a nice to have, it's a must have, because they're planning on being there for the long haul. So again, wanted to thank all of the panelists and all the participants and organizers for such a great session today, and I hope you enjoy the 15-minute break before the next session. And plugging the session tomorrow, thank you for
8:30 this room.
8:30 in this room, we're going to talk about management models for Washington healthcare facilities. Thank you.
Thank you. Sorry, just I want to remind us to warmly thank all our conveners. We had from ACHAP, the Dicastery for Integral Human Development, Water Mission, World Vision, and CRS. Our friends from CUAMM, Doctors with Africa, were not here for conflicting priorities, but were at the initially with us to prepare this side event. And again, thank you for the support for facilitation from Nikki and Ryan from UNC and Lindsay from UNICEF. A warm thank you to all of them.
And Jean-Philippe for your coordination. Thank you.
Lastly, in case you want to share comments, get into contact with some of the group, you can use my email here, and then I will redistribute. Thank you. Bye.
If you want to join the community practice, how do you do it, Ryan?
Come talk to us.
There you go. There he is. Oh, thanks.
Can we have a photo with all the panelists and speakers, please? Panelists and speakers.
Hi, Andreas. Good to see you. Yeah.
Thank you.